So now we know the gingival recession around the implants, it's whatever disalignment of the soft tissue margin of the implant-supported crown with respect to the ideal position of the soft tissue margin. The ideal position of the soft tissue margin is most of the time determined by the position of the soft tissue margin, gingival margin of the adjacent homologous tooth. So we may have gingival recession around the implants that are elongation of the crown, 3 millimeters of crown that is longer than the adjacent tooth. Obviously, it's a gingival recession, but with no metallic exposure. Only once we go more apical and we reach the metallic, the gingival recession, it's also associated with metallic exposure. And the metallic exposure can also be of two different types. It can be only the abutment or the smooth color that is exposed, or it can be true implant surface, rough thread exposure. And it is only the last one that is strictly connected to the absence of the buccal bone. The other gingival recession, that one showing elongation of the crown with or without abutment exposure, can simply be the consequence of not enough soft tissue thickness independently on the lack of the buccal bone. So gingival recession, by definition around the implant, is a disalignment of the soft tissue margin at the level of the implant-supported crown with respect to the ideal position that is determined by the position of the gingival margin of the homologous natural tooth. The objective of the therapy is to cover. To cover what? To cover only the metallic exposure? No. It's to cover the implant-supported crown so that the soft tissue margin of the implant-supported crown is restored to its ideal position, which is the same level of the soft tissue margin of the adjacent homologous tooth. And since we want to cover also the crown, implant-supported crown, so that they are exactly the same level of the adjacent tooth, we know for sure that we cannot achieve attachment. So the soft tissue that we will use to cover the crown, to cover the abutment, cannot attach to anything. While the soft tissue that is covering the root can be attached to the root if you apply root planing, ADTA, and amelogenins. The soft tissue we will use to cover the implant crown cannot be attached to nothing below. So in order to have this teeth so stable, despite it is not attached, it must be very, very thick. And the minimum thickness of tissue, of connective tissue, that we need to cover the implant-supported crown, as we said, is 2 millimeters. No less than 2. And if we want to cover something that is gray, so metallic, we need even 3 millimeters of soft tissue thickness in order to mask completely the transparency. So in the case of teeth, the most important objective is to cover with tissue thickness that it's not so increased because it can be attached to the suprabony component of the root. In the case of implants, we need, for sure, to increase soft tissue thickness so much, more than 2 millimeters, because we know that this tissue, covering the crown, covering the abutment, cannot be attached to any of the underlying surface. Did I mention keratinized tissue? No. I spoke about soft tissue thickness because, as I told you, it is the thickness comprised between the external and the internal epithelium that will make the soft tissue margin stable. Even if patient toothbrush or even if plaque accumulates, the area occupied by the inflammatory process should be smaller than the connective tissue comprised between the external and the internal epithelium, so this will never recede. So it's a problem of thickness. The keratinization of the epithelium, it's a characteristics of the epithelium that can be more or less keratinized. But this is not enough. We may have tissue that is very, very nicely keratinized, but the thickness comprised between the external and the internal epithelium is so small that it will recede immediately if the patient is traumatic in the toothbrush or if plaque accumulates, because the thickness of the connective tissue comprised between the external and the internal epithelium, despite the epithelium is so keratinized, can be very, very thin. So the objective of therapy is not to create keratinized tissue. The objective of therapy is to create a new transmucosal zone through which the crown emerges very naturally. And the key to have this transmucosal zone stable with time is to have a thickness of connective tissue that is greater than the inflammatory process, so more than 2 millimeters. To have keratinized tissue or not, it's something that can be good because the patient also clean better. It's more confident in the toothbrushing technique if you have keratinized with respect to not keratinized. But it's not the keratinization of the epithelium that prevents gingival recession to form around the implant, but is the thickness of the connective tissue comprised between the external and the internal epithelium that must be greater than the inflammatory process. So what we have to do is not only to cover, but to increase soft tissue thickness more than 2 millimeters in the area where the tissue is covering the crown and is covering the transmucosal portion of the implant-supported crown. Why gingival recession forms around the implant? As we said, this is mainly due to bad implant installation, buccal lingually, mainly, sometimes also apicocoronally, and we all agree with this. What I don't agree so much is that also thin biotype and lack or thin buccal bone are considered etiological or factors associated with. I don't agree because what does it mean, thin biotype for implant? Because, you know, all patients are considered to be thick when the soft tissue thickness is 1.5. But 1.5 soft tissue thickness is never enough for implant in the transmucosal zone, because in the transmucosal zone, soft tissue thickness should be greater than 2 and sometimes 3. So can we really use the same parameters that we use for teeth, thin and thick biotype that now are called phenotype? Also for implant, I think that if we think different, we can say that there is no patient, there is no biotype, there is no phenotype that is thick enough by itself in the case of implant to give stability to the soft tissue margin in the transmucosal zone. So for sure, the thickness of the tissue is very important, but there is no patient that is thick enough for giving stability to the soft tissue margin at the level of the implant-supported crown. What about the bone? Obviously, if the implant is placed too much buccally, there is no buccal bone. But it's not the buccal bone itself that creates gingival recession. As I told you, It is the crown that is even more buccally, and so the soft tissue is never thick enough spontaneously to remain stable if the crown is so buccally displaced. The presence of the buccal bone or the absence of the buccal bone, it's something that can increase the risk of implant exposure, thread exposure, rough implant surface exposure. And this is bad, because if there is gingival recession with no implant exposure, we can make soft tissue treatment only, while if there is gingival recession with also implant exposure, we need also to decontaminate the implant surface that being exposed is contaminated by oral bacteria, and we know that decontamination of the implant surface is something that we are not so good, we are not so predictable, even if tomorrow we will see if there is something that we can do to decontaminate the implant surface, because what we are speaking about is not implant affected by perimplantitis. We are speaking about implant that is perfectly integrated into the bone that experience gingival recession because of the too much buccal displacement. And even if there is contamination of the implant surface, this is limited to the buccal surface. And the contamination is secondary to the exposure of the implant surface because of the recession. So we don't have infrabony component. We don't have an infection. We just have to clean a surface that is exposed to the cavity. Obviously, it's easier to clean the root because we can make root planing, while it's more complex to clean the implant surface because it's more rough, it's more complex. But today there are some good tools like the titanium microbrushes that helps us a lot because of the very good visibility, the very, very good access to clean the implant surface when this is exposed due to gingival recession. But it's very important that you distinguish those cases in which there is perimplantitis, and due to perimplantitis, there is also gingival recession, from those cases in which the implant is perfectly integrated into the bone, there is a bad implant placement, and due to the bad, too much buccal implant placement, there is no buccal bone, and this implant surface can become exposed, but this is not primary infection. This is secondary infection to implant exposure. Now, it's very important to understand what is a buccal bone dehiscence. Buccal bone dehiscence means that there is implant exposure at the buccal aspect. But we may have two different types of buccal bone dehiscence. One is due to the lack of bone. So there is lack of bone, but the implant is placed in the right position, so much more palatally than the position of the bone. Or we may have a buccal bone dehiscence because the implant is placed outside of the bone. So it's a mistake in implant positioning that created the buccal bone dehiscence. And this is completely different in the possibility we have to cover this implant surface. Because if the implant is placed inside to the bone and there is buccal bone, we want to create new bone. So the main objective is to make bone augmentation because there is a space between the ideal position of the bone and the implant surface for bone regeneration. So we can use bone of the patient, we can mix bone of the patient with bone filler materials. It doesn't matter so much, but the main objective is to generate bone because the dehiscence is due to buccal bone loss. The buccal bone loss can be due to fracture, periodontal disease. In this situation, we are in a completely different situation because it's not lack of bone. It is the implant that was placed outside because of the bad implant installation outside of the bone. So in this situation, it is the implant that is outside the bone, not lack of bone. So in this situation, if you want to have new bone at the buccal aspect of the implant, the only thing that you can do is to remove the implant, place it more palatally, and regenerate bone. So one is buccal bone dehiscence that is due to bone loss that can be treated with bone, membranes, and the treatment of bone and membranes don't exclude the need for increasing soft tissue thickness in the suprabony area. So the use of bone, the use of membranes don't exclude at all the need of connective tissue graft in the most corner area where we also want to increase the thickness of the tissue, preventing gingival recession to form at the level of the soft tissue margin. While in the case of bone dehiscence due to buccal placement of the implant, we cannot make any bone augmentation, but we have to use only the soft tissue, both suprabony and also infrabony, in order to cover the metallic exposure and give right thickness to the soft tissue margin. What we do in the treatment of gingival recession around the implant due to bad implant installation is exactly the same treatment we did for treatment of gingival recession around teeth, where the root, like the implant, is placed so buccally outside of the bone that the only way to treat is by soft tissue grafting and not hard tissue grafting. This is very important because when you select treatment procedure, what you have to understand if the lack of the buccal bone is due to bone loss, and so you can regenerate the bone. But if the lack of buccal bone is due to the buccal displacement of the implant, the only thing that you can do in order to repair this mistake is soft tissue grafting. So there is a lot of similarities between treatment of gingival recession around teeth and implants because it's only soft tissue procedure and not hard tissue procedure, because the dehiscence of the implant at the buccal aspect is due to bad implant installation and not to the lack of bone. And the reason why this gingival recession occurs, it is because if the implant is placed outside, the crown is even more buccally. And with such a buccal position of the crown, there is no how for the soft tissue to cover it, because this soft tissue that should cover the crown, it's so buccally displaced that the blood supply to this tissue at the level of the papilla, it's so palatally with respect to the area that we want to cover, that this papilla, it's so weak, it's so palatally displaced with respect to the area that we want to cover, that we cannot be predictably, if we try to cover the implant-supported crown in the same way we cover the natural tooth. How much the absence of the buccal bone, how much the malpositioning of the implant with respect to the bone housing influence the prognosis of root covering? I have to tell you, not so much. So, in my opinion, even if there is a lot of implant that due to bad implant placement don't have any buccal bone, this is per se not an indication or a reason good enough to extract the implant. It's more important to understand if this implant surface that is for about 50% outside of the bone housing is also contaminated or not. That's more important for me from a prognostic point of view, because if this implant surface is also contaminated, I have the problem to be predictable in decontaminating it. While if the implant surface is outside of the bone, there is no bone, but it was never exposed to the bacteria of the oral cavity, the only thing I have to do is to increase the thickness of the tissue, but I don't have the problem of decontamination. And how do you know if the implant surface that you can see outside of the bone in the cone beam, it's really contaminated or not? Two ways. If you see it exposed, you see the thread exposed, it's obviously it's contaminated. But I don't see, for example, in this case, I don't see any thread. So I have to be careful in order to say, okay, this is contamination. Because before saying it's contaminated, I have to see that the soft tissue here is detached from the implant surface. So the best way to understand if the implant surface exposed from the bone, it's also contaminated, is by probing it. And when you use a periodontal probe and try to probe the soft tissue margin, you don't penetrate at all if there is still good integration. And this is obvious because different from the root that is smooth, the implant surface is very convex, macro and micro, and so the connective tissue integration is so tight that you never penetrate. If you try to penetrate with a probe here, most of the time you tear the tissue, but you are not able to penetrate because it's very, very complex integration. Even if it's not fibers inserting perpendicular to the implant surface, they are so tightly parallel and circular around the implant, they don't allow any penetration. But the most important thing is if there is no penetration, there is no contamination. And if there is no contamination, it means I don't have to decontaminate it. It means that my covering procedure can be much, much more easy to be much more predictable in long term, because if there was no contamination, despite the presence of such a thin tissue, it will be even less at risk to be contaminated once the thickness of the tissue will be increased. So, no doubt, it's not a question of bone augmentation. It's only a soft tissue augmentation procedure. And in order to augment soft tissue thickness enough, more than 2 millimeters, we have to use a connective tissue graft for sure. And this connective tissue graft should be used in order to replace the soft tissue margin in the ideal aesthetic position, but with a greater thickness. So where should be the connective tissue graft applied in terms of apicocoronal position is just a bit more coronal to compensate shrinkage with respect to the ideal position of the soft tissue margin. So if this is a lateral incisor, I want to know where should be the position of the soft tissue margin of the lateral incisors, and the connective tissue graft should be placed 1 millimeter more coronal. So by definition, rule of thumb, the connective tissue graft should be applied 1 millimeter more coronal with respect to the ideal position of the implant-supported crown. The problem is that in such a coronal position, how can the graft survive? How can the graft survive on the crown? How can the graft survive on the abutment? Everything is avascular below, yes or no? And so the only way for the graft to survive is being covered. Because being covered, the survival of the graft is not related anymore to the blood supply coming below, but from the blood supply coming from the covering flap. But the problem is, how can the flap be stabilized on the graft, remain covering the graft? You need to give some blood supply to the flap in a more coronal position with respect to where you place your graft. And the only vascular area coronal to the connective tissue graft is the area of this papilla. But how are these papilla? Very weak. Why? Because they don't have the same intact bone peak of the teeth. They are very, very palatal displaced. Not because the papilla is palatally displaced, but because the crown is extremely buccally. And so compared to the surface that you want to cover, you have very, very palatal displaced papilla that gives you very, very weak blood supply. and they are so triangular, so thin, so narrow, so squeezed, that if you desepithelize them, how much blood supply can this papilla give to the surgical papilla of the flap? Zero. So this is why, if you try to cover implant-supported crown as it is with the bilaminar technique, you are going to fail. You are going to fail. Why? Because there is no good papilla enough for giving stability to your coronary advanced flap that should cover the connective tissue graft. So, treatment plan. First question, where should be the connective tissue graft applied? 1 millimeter more corner with respect to the ideal position of the soft tissue margin. Which kind of connective tissue graft are we speaking about? No doubts. Free gingival graft, desepitalized extraorally, because we want to have very, very stable, dense, collagen-rich connective tissue that masks completely the transparency of the underlying surface and must be so stable that with time also increase in thickness. So there is only one type of connective tissue graft that can give you this predictable outcome. Free gingival graft, desepitalized. How big should be the graft? Only in the middle? No. We want to increase also papilla thickness, yes or no? Otherwise, this papilla, if you don't increase the thickness of the papilla, they will not grow in coronal direction and will not be squeezed back with the conditioning phase. And so you lose papilla height during the surgical procedure because they are weak papilla with no bone peak. And so the connective tissue graft should be extended mesially and distally to include all the mesial and distal papilla. But now, is this papilla good enough to anchor the graft, to anchor the flap? No! Never. Never. And this is mainly because there is this crown overhanging, very, very buccally. So if you remove the crown and if you reduce the abutment to make it as thin as possible, as narrow as possible, and place a very short temporal crown and leave the time for the soft tissue that previously was squeezed by the crown to completely fill the space between the very, very narrow and thin abutment and the two adjacent teeth, you now can work with very, very large papilla that, compared to the first papilla, instead of being triangular with a very, very narrow tip, it's large with a soft tissue isthmus that makes the thickness, the width, but also the bacolingual dimension of the papilla enormously bigger than the papilla where there still was the crown. So now we don't have to cover the crown anymore, but we have to cover an abutment that is extremely thin. It has been corrected in order to correct as much as possible the malpositioning of the implant, and so the papilla are much, much more buccally displaced with respect to the abutment surface, with respect to the papilla where there was still the crown. So by removing the crown and by changing the abutment with a very, very narrow and very, very thin, we completely change the relationship between the connective tissue graft and the area of the papilla remaining coronal to the graft. So now these papilla, yes, are large and not being the tip anymore, but being a soft tissue isthmus, can be desepithelialized not only in the vertical dimension, but also into the horizontal surface towards the most palatal extension, because there is continuity from the buccal to the occlusal to the palatal aspect of this papilla. So the amount of blood supply that you can give to your coronally advanced flap to cover the graft, despite the graft it's so coronally positioned, it's about 4, 5, 6 times more with respect to the blood supply you can give your flap if you leave the crown in situ. So now, by using this blood supply coming from the wider papilla that can be desepithelialized towards the palatal aspect, we can predictably cover a connective tissue graft that will be placed in such a coronal position, namely 1 millimeter more coronal than the soft tissue margin of the adjacent natural tooth. So when the patient comes with gingival recession around the implants, the first thing to do is to tell the patient that the crown has to be removed, the abutment has to be changed in order to make it as narrow, as thin as much as possible, increase the space between the abutment and the two adjacent teeth, and leave the tissue fills this area. And if you see that during this phase, there is areas where some of the tissue that can be gained, it's still occupied by the temporal crown, you have to further reduce the temporal crown in order to allow the soft tissue completely fill the space. So the more narrow, the more thin is the abutment, the more short is the temporal crown, the more is the space that is left available for the papilla to fill and to become larger, thicker, mesiodistally, buccal lingually. So this papilla is now really wider and thicker and can be used towards the palatal aspect. How long it takes to change this papilla from this very, very small vascular bed? Almost nothing, very, very palatal compared to the surface that we have to cover. Very, very triangular, no isthmus, so only in the vertical dimension can be desepithelialized compared to this vascular bed, which is flat, but very wide, very, very thick in the buccal lingual dimension. Blood supply here is 4 or 5 times bigger. How long it takes for the soft tissue to completely fill the space that was previously occupied by the crown and by the abutment? No less than 2 months. So you have to ask the patient to wear a short temporal crown for 2, sometimes 3 months. The more the implant is closer to the adjacent teeth, the more it takes time for the tissue to fill it. And before saying that there is no way to treat an implant and to cover an implant, you have to make the pre-surgical phase. This is called pre-surgical phase. Remove the crown, change the abutment, apply a short temporal crown, and leave the tissue fill the space, because if this tissue becomes papilla that can be extended in its desepithelialization towards the palatal aspect, now you can really more predictably cover your implant independently on the bone peaks, independently on what is the bed or the buccal malpositioning. You see that here the abutment was temporarily removed before starting the surgical procedure, because it's easy, or it's easier to manage the flap for covering the graft with no abutment. But the abutment will become protagonist again during the surgical procedure, once it will be the time for applying the connective tissue graft, because I need a surface here that allows me to apply the connective tissue graft in the right coronal position, namely 1 millimeter more coronal with respect to the ideal position of the soft tissue margin. This is called prosthetic surgical approach. That is the most predictable approach to cover recession around the implant. It's not only a surgical procedure. Patient comes, the crown is removed, the abutment is changed, a temporary crown is applied, cemented temporary crown, so you can remove it. If there is a space that the soft tissue still has to feel, you reduce it even more, you wait 1 more month so that the soft tissue is now intact and completely filling the space previously occupied by the crown, previously occupied by the whole abutment, and now you can perform a surgical procedure with enormous amount of blood supply for your surgical papilla that instead of being advanced only in the cornal direction like it is for teeth, yes, we advance the papilla in cornal direction. In this case, we will advance the papilla in the palatal direction in order to cover the anatomic desepithelialized papilla to the most palatal extension of this tissue that was created with the pre-surgical phase. And once the papilla goes palatally, the buccal flap goes coronal, because at the end of the surgery, I will apply my abutment with my connective tissue graft that will make the connective tissue graft in the right position compared to the soft tissue margin of the adjacent tooth.